All right, today we're going to dive deep into a condition that honestly hides in plain sight, affecting teens right when they're in their biggest growth spurts. It's called slipped capital femoral epiphysis, or SCFE for short. And believe me, it's a huge deal for the future health of a teenager's hip. So yeah, let's get right into it. In this explainer, we're going to break down exactly what's going on inside that hip joint. We'll look at how doctors actually spot it, and most importantly, we're going to walk through the nitty-gritty of the surgical techniques they use to fix the damage and save that joint. And that right there is exactly why we need to talk about this. Think about it. The most common hip problem for this age group is also one of the ones that's most often overlooked. That can have some really serious consequences. So, understanding this is absolutely crucial. Okay, so let's start at the very beginning. What in the world is a slip, and what's actually happening inside the body?
So, a scuffy happens right at the growth plate, the physis, which is actually the weakest spot in a teenager's bone. The ball, which is called the femoral head, literally slips backward and downward off the top of the thigh bone. And honestly, the ice cream analogy? It's perfect. The cone is the thigh bone, the scoop of ice cream is the ball of the hip, and the slip happens right where they meet.
Now, it might not be a household name, but the numbers here are pretty significant. We're talking about 10.8 out of every 100,000 kids, and it usually hits right in the middle of a massive growth spurt. It's also a bit more common in boys. And it's worth noting that obesity is the single biggest risk factor. All right, so why does this get missed so often? Well, the diagnostic process itself kind of tells a story of these really deceptive symptoms that can easily send a doctor looking in all the wrong places. Okay, so the symptoms are notoriously tricky. The pain can be kind of vague, it comes and goes, but the classic trap here is knee pain. I mean, in up to half of all cases, the only thing the patient complains about is pain in their knee or their thigh. This is what's called referred pain, coming from a nerve called the obturator nerve, and it's this classic red herring that can delay the right diagnosis for weeks, sometimes even months. So during a physical exam, a specialist is looking for some very specific clues, and the biggest one is called the Draymond sign. What you do is you passively bend the patient's hip, and as you do, the leg just uncontrollably starts to turn outwards. It has to. That's because the slipped part of the bone is physically bumping into the hip socket, forcing that outward motion. It's a huge giveaway. Then you get to the X-ray, and for a long time, the definitive sign has been Klein's line. It's simple. You draw a straight line along the top edge of the neck of the femur. In a healthy hip, that line should cut right through a piece of the ball at the top. But in an SCFE, because that ball has slipped down and back, the line either misses it completely or just barely skims the edge. But, and this is a really crucial point, a 2009 study in the Journal of Pediatric Orthopedics found something pretty shocking. It showed that the classic Klein's line can actually miss a huge number of subtle slips. This just goes to show you that making the diagnosis requires a ton of suspicion, and a lot of the time, looking at the other hip to compare and spot even the tiniest bit of asymmetry. So once SCFE is diagnosed, it's considered a surgical emergency. The goals of the surgery are really twofold. First, stop that slip from getting any worse. And second, prevent the absolutely devastating complications that can come next. Now, before any decisions are made, surgeons classify the slip as either stable or unstable. And this distinction, it's everything. It's the single most important factor for prognosis. A stable slip means the patient can still walk, maybe with crutches. That's about 90% of cases, and the outlook is much better. An unstable slip, though, that's a true emergency, carrying a much, much higher risk of serious problems. So we get to the critical question, how do you fix it? Well, the surgical toolbox has a few options, ranging from a pretty simple stabilization to some really complex bone realigning procedures called osteotomies. Let's break those down. For the vast majority of stable, mild to moderate slips, the gold standard is something called in situ pinning. Now, the goal here isn't to fix the deformity, it's just to stop it from slipping anymore. A single screw gets placed right across that growth plate, basically locking it down and preventing any more movement. It's actually a very elegant and incredibly effective solution, with good results in over 90% of cases. But what about the really bad slips? Or what if the deformity causes problems down the road? Well, that's where osteotomies come into play. This is a much bigger operation where the surgeon intentionally cuts and realigns the bone to try and restore a more normal anatomy. For those severe, unstable slips, one of the most powerful techniques is the modified Dunn osteotomy. The goal here is really ambitious.
to get a full anatomical correction. To do this, it actually requires surgically dislocating the hip. This gives the surgeon direct access to the slip so they can separate the femoral head from the neck and pin it back exactly where it's supposed to be. It's a complex procedure, for sure, with a pretty steep learning curve.
Okay, so what if a patient had that simple pinning procedure, but years later they start having pain because of the deformity that was left behind? It's a condition called femoroacetabular impingement. For that, a procedure like the Eimhauser osteotomy can be a great option. Instead of trying to fix the slip right where it happened, the bone is cut a little lower down to change its overall angle. This improves the hip's mechanics without messing with the very delicate blood supply around the top of the femur. So, looking at this table, you can really see the whole risk-reward calculation for each surgery. In situ pinning is safe, it's effective for just stopping the slip, and it has a low risk of messing up the blood supply. The modified done gives you that perfect anatomical fix, but comes with a significant risk of avascular necrosis, about 26%. And then the Eimhauser provides that compensatory fix with a much, much lower risk profile. And that brings us to the single most feared complication, and the ultimate reason why every single day matters when diagnosing SCFE, and that's avascular necrosis. In unstable slips, the risk of avascular necrosis, or AVN, can be as high as 47%. What that means is the slip has disrupted the fragile blood supplies to the femoral head, and the bone literally dies. This is, well, it's a catastrophic outcome that almost always leads to early, painful, debilitating arthritis. Just look at this x-ray. It shows you exactly how severe that displacement can get. You can almost see how the tiny arteries that wrap around the top of the femur could get stretched or kinked or even torn by this kind of slip, just starving the bone of the blood it needs to live. And that brings us right back to where we started. SCFE is a common problem, but it's also commonly missed. The stakes are incredibly high, and the difference between a stable and an unstable slip can genuinely change a kid's life forever. So it leaves us with a pretty critical question, doesn't it? What can we do to make sure that any teenager who has a limp and complains of thigh or knee pain gets the right x-ray at the right time